Hey, how are you doing?
Not bad. How about you?
Good, Dr. Salomons. Hi, everybody. I am Raji Amrus. I'm the founder and CEO of the San Diego Pain Summit, and we are here for our next presentation with Dr. Tim Salomons, who is joining us from, are you in Canada now? Or?
Kingston, Ontario.
Kingston, Ontario. Okay, so I did have the right country.
Yeah, that's right.
So, I'd like to introduce you real quick to the audience, and I just want to remind everybody who's watching from within the Gamer Jive, there is a 2-minute lag, so I just want you to be aware of that. Tim Salomons is interested in the cognitive and biological mechanisms that make pain salient and how individual differences in these mechanisms might underlie differences in coping and treatment response. His work aims to understand how the brain and body interact to create the experience of pain and why some people might be prone to develop pain, while others are relatively resilient. He's especially interested in the biological mechanisms. Oh, wait, I just read that. Oops. Looks like I just printed something twice.
Makes me sound twice as important.
Yeah, and I just started reading it. So, and before we get started, is there anything that you would like to share with the audience?
Well, I've got a little object here that I thought maybe I'd share because, so this is, I was born in Saskatoon, Saskatchewan, which is in the middle of the Canadian prairie. It's a very cold but lovely place. And my dad, as a young kid, bought this lovely piece of indigenous Inuit soap sculpture. And for about 40 years, he had this sitting in his office. My dad was a pastor, and so he spent a lot of his time in his office reading and doing all of his stuff. And I had coveted it for years, and he has recently retired. And so I begged him to give it to me. In the meantime, my parents moved house, and my mom, not knowing that I wanted it, gave it to the local discount shop. And then when I raised a fuss, she had to go buy it back for me. But now it sits watching me through all my Zoom calls, and it's, provides wisdom and inner peace. So I thought that would be
really
a good item to show.
Thank you for showing that.
Yeah, absolutely.
It looks like you've held it a lot because the soapstone has become very smooth and shiny.
Yep. It's weathered a lot of days in the study. So
cool. Well, thank you so much for sharing a piece of your everyday life with us here at the SD Pain Summit, Virtual Pain Summit. So what I'm going to do now is just play your presentation, which, just to remind the audience, is pre-recorded, but we are live right here, right now. When the presentation has done playing, we will reappear and take your questions. I will also post an announcement. Please remember that all questions go to questions.
Hi, everybody. I'm Tim Salomons, and my talk is called All in Your Head, Biomarkers of Vulnerability and Resilience to Pain. I'm going to start out with an all too typical clinical encounter. This patient has had knee surgery a while back, and he's going in for a checkup. Doctor probes around and says, "How does this feel?" Patient says, "It hurts." Doctor wants to know a little bit more about what he's experiencing. "What do you feel?" Patient says, "I can't describe it. It just hurts." Doctor says, "Well, it's been 8 weeks and the surgery was a complete success. It shouldn't hurt anymore." A little puzzling for the patient. "I don't know what to tell you. It still hurts." Okay. Of all the clinical and research problems we face as a pain community, the most difficult might be the broad range of individual differences in pain responsivity. Some people's pain goes away quickly, and even if it sticks around, they're able to cope with it relatively well and live happy and productive lives. Other people's pain doesn't go away, and they seem to get stuck in a negative spiral of pain and unpleasant emotion. So the pain might cause stress. I mean, pain usually does. It's very difficult to live with pain. And that stress, in turn, exacerbates their pain. And the two feed off of each other, and the person gets relatively stuck into a persistent clinical problem. Now, unfortunately, strong evidence shows that in the absence of symptom certainty, when we don't know what is causing the pain, the presence of negative emotions leads clinicians to take the pain less seriously and all too often to undertreat them. Given that women are generally better and more willing to express their emotions, this also results in systemic sexism in pain treatment, as evidenced by terms like hysterical pain. This was not helped by the IASP's note accompanying their famous definition of pain. In that note, they said, many people report pain in the absence of tissue damage or any likely pathophysiological cause. Usually, this happens for psychological reasons. I find that quite perplexing. Quite perplexing and bothersome. I find it bothersome because it amounts to a pseudo-mechanism. As soon as we tell people that pain is all in their head or attribute it to psychological causes, we act as if we figured it out. But the truth is we've figured out nothing. We have no viable mechanism by which a poorly described psychological state might result in somebody experiencing pain. So this pejorative declaration not only dismisses the patient's concerns, but it generally halts our search for an actual mechanism. It's clear that what we need are ways to characterize people's vulnerability or resilience to pain in ways that point us more directly to the actual biological mechanisms for these individual differences. One potential biomarker is neural activation. Since the mid-1990s, we've been using tools like fMRI to find the brain regions that light up when people are in pain. And nearly every one of these studies has found a similar pattern of activation. It's outlined in this image from a meta-analysis by Abkarian and colleagues. We see the anterior cingulate, we see the insula, we see the thalamus, we see the primary and secondary somatosensory cortices. And that is backed up by this later quantitative meta-analysis done in a tool called Neurosynth. Here we see, on the right, we see 300 pain imaging studies meta-analyzed, and the reliable activation is in the anterior cingulate, the insula, the thalamus, etc., etc. This pattern of activation is so ubiquitous in pain studies that we started to call it the pain matrix. And truth be told, if you run a pain study and you don't see pain matrix activation, you've probably done something wrong, okay? And we also found that this pain matrix is sensitive to people's psychological state while they're in pain. So in this early 2004 study that we did, we found that the pain matrix activation was also dependent on whether people perceived control over their pain. If they felt that they were experiencing pain they couldn't control, they had more activation in regions like the anterior cingulate and the insula. Now, this seems promising. This seems like a very promising biomarker for understanding individual differences. But we have to ask a couple of critical questions about what this activation means. The first question is whether these regions are necessary for pain. Okay? Neuroimaging is a correlational science, and essentially you're just seeing while somebody is having pain, what is lighting up? Well, those lit up regions may be epiphenomenal. They may just be occurring while somebody is in pain, but they actually aren't necessary for that pain to take place. So to investigate this question, we looked at the following patient. So here I'm going to show his response to a 49-degree thermal stimulus applied to his forearm.
Ow! Wow! That's
So clearly they have a very intact pain response, and you saw a clear emotional component to that pain. I'm also going to show you this patient talking about how they cope with pain, how they contextualize the pain that they experience. So what's an example of something that might be painful that doesn't bother you?
I have to poke my finger and get a piece, the spot of blood and do a blood test, and I'm diabetic.
Mm-hmm. And that doesn't bother you?
Painful, and you have to do it.
Okay. So because you have to do it,
Yeah,
it doesn't bother you as
my
much?
shot, I have to do a shot.
Mm-hmm. So what this patient is telling us is that they're able to modulate their pain response based on whether it is helpful to them or not, okay? Because pricking his finger occurs in the larger context of his health, as in if I prick my finger, I will be generally more healthy, he's able to reduce his emotional response to pain. So that would seem to be a core component to how one would cope with pain, okay? To be able to contextualize it and put it, think about it in a different way. Now I want to take a look at this individual's brain. Now this is not just a shadowy slide. All these regions you see in black are lesioned. Okay, this due to post-herpetic encephalitis that occurred about 30 years before we saw them. This patient has nearly complete lesions to the insula, the amygdala, the anterior cingulate, and several other key pain matrix regions. And what this indicates is that even when we know what regions are commonly associated with pain, we cannot take for granted that these regions are necessary for pain. Now, of course, because we tested this patient so long after they experienced the lesions, it is possible that other regions took over due to pain's important adaptive function. Nevertheless, this causes serious questions about the necessity of these regions and whether what we observe in these pain studies is truly the neural signature that is leading to pain. And if anyone wants to read a little bit more about this fascinating case, we documented it in a 2015 paper in Brain Structure and Function. The next question we want to ask is whether these regions are sufficient for pain. When we see activation in the pain matrix, is that sufficient evidence that pain is occurring? In order to ask this question, we found a patient with congenital insensitivity to pain. And I'm just going to play this little video clip that gives you a feel for what that is like.
The last time I broke my foot, it was actually out in the woods and it was nighttime, so it's pretty much like walking around with your eyes closed. Mm-hmm. And when I broke my foot, I didn't instantly know that I did it because I was stepping over a stump, and when I stepped over, there was another log on the opposite side of it that my foot had got wedged into, and it twisted it, and I fell over and cracked it. And I didn't know that happened until after I tried to get back up. And when I got back up, I went to go put my foot down, and I could hear the cracking of bone, but then also I had like this, like a rush feeling, like a kind of like just like blood, like it felt like blood was going through my leg, kind of is what it felt like, but I wasn't actually bleeding.
So as you can hear, this individual sustains a terrible injury, but is incapable of feeling pain due to a genetic deficiency in his nociceptive processing. So clearly the question of interest to us was what would happen in his brain when he receives a stimulus that somebody else would find painful. So we gave him and another individual with congenital insensitivity to pain a sharp mechanical stimulus that other people, healthy controls, found painful, sort of like being poked with a sharp pencil or something. And we compared their brain response to the healthy controls who rated the stimulus as painful. And what we see is that they have nearly identical activation within the so-called pain matrix. In red, we see the neurosynth-defined pain matrix. In blue, we see a conjunction mask of activation experienced by all of the healthy controls. In yellow, a conjunction mask of all the patients. And we see no differences between the groups when we examine individual pain matrix regions, okay? We see no difference in the thalamus, in S2, in the anterior cingulate, or across the entire pain matrix. What this indicates is that simply observing pain matrix activation is not sufficient evidence that an individual is experiencing pain, and this is therefore a highly nonspecific response. Now, what I don't want you to take away from this is that somehow fMRI is useless or that these regions aren't involved in pain at all. But it's clear that we need to do a lot more work to specify the processes that are going on in these regions and how they might affect the pain experience. In the next segment, I'm going to show some of the work we've done to characterize neural responses that underlie individual differences in how people respond to pain.
Dad! Dad! Dad,
Oh, hey, love. What's up?
the washing machine won't start. What are you doing?
I'm making a video for the San Diego Pain Summit.
But you're still wearing pajama pants.
Oh, they're never going to know. So in the last segment, I discussed two different ways of characterizing individual differences in pain and in emotional modulation of pain. I talked about how too often individuals' vulnerability to pain is dismissively attributed to psychological factors without any attempt to tie this to a plausible biological mechanism. On the other hand, I talked about the limitations of taking what we might call a naive biological approach, where we identify biological markers without any attempt to identify the processes that these patterns of activation are associated with. I'm going to show some recent studies from my lab that attempt to characterize individual differences by linking brain and behavior and giving us a better idea, hopefully, of the processes that these biological signals are involved in. Now, there's a few brain regions we've been focusing on. By no means is this an exhaustive list. In the studies I'm going to show, we're looking at seed-based functional connectivity. So we take a particular region and we see what it is connected with in the brain. And this approach reflects kind of an evolving understanding in the imaging community of how the brain works. When we first started, we took a largely modular view. We would say, okay, let's find the laughter center in the brain, or let's find the pain center in the brain. As we've become more sophisticated and in line with what was already known in neuroscience, the brain isn't a set of independent nodes. The brain is a series of interconnected regions that work together in concert to accomplish the mental processes we need to accomplish. So part of the reason that we choose these particular seeds is their involvement in well-known networks we would anticipate being involved in these processes. Now, this is not an exhaustive list of the networks or regions that might be involved. I'm focusing here on these three because there are three that we've studied recently, and it helps to convey the approach we're using. Now, one of the regions we're interested in is the periaqueductal gray. This is an opioid-rich brainstem region. It's known to be involved in fight or flight responses, but many of you may know it instead as a region that is involved in the descending modulation network for pain. It's able to send signals down to the dorsal horn of the spinal cord to either inhibit or facilitate incoming nociceptive signals. And quite importantly, within the context of this talk, this region also receives signals from brain regions involved in cognitive and affective responses, which gives it potentially a critical role in how thoughts and emotions modulate the experience of pain. Now, one of the emotion regions that's connected to the periaqueductal gray, or PAG, is the amygdala, which plays a prominent role in fear and other emotional responses. It's part of what neuroscientists call the salience network, which is a set of regions, including many of the quote-unquote pain matrix regions, that is involved in any task that demands our attention and action. In contrast to the salience network, the default mode network is actually deactivated when we're engaged in something that captures our attention. It's been associated with things like mind wandering, and self-referential thought. Abnormalities in this network have been associated with chronic pain as well as depression, and it's known to be influenced by mindfulness. Key regions are the medial prefrontal cortex and the precuneus. And the precuneus is the seed that we're going to use in the study I'm going to show in a minute. You see it in the diagram on the far right in green. So the first study I'm going to show is a study I did while I was a postdoctoral fellow in Karen Davis' lab at the University of Toronto. It came out in PNAS in 2013. Here we examined something called intrinsic attention to pain. And I'm going to explain to you what that is and how we measured it. Now, the design is pretty simple. So simple, in fact, that I have to admit, didn't believe it was going to work. And I said, I don't know why you guys are bothering with this. I was kind of the skeptic on the project. And luckily, the lead author, Aaron Kusi, who's now at Northeastern, pushed this forward. Basically, what we did is we gave people a 20-second long pain stimulus calibrated to their kind of 5 out of 10 rating. And we asked them a simple question. While that stimulus was going on, to what degree were your thoughts or feelings just on pain or something else? So to what degree were you paying attention to the pain while it was on? What we calculate then a score. So, only pain is a 2 and only something else is a -2. So a positive score indicates a tendency to attend to pain or an inability to attend away from pain, perhaps. Importantly, we measured this at 2 time points and we found high test-retest reliability. And that's important if you want something to be an individual difference marker, because you need to know that if you measure it at one time point, you will get a reliable score at another time point. It's stable within the individual. And then in a separate session, we had people do a kind of Stroop task. We asked them, how many numbers are there on this card? Well, if we look at, one of these, we might ask people, how many numbers are on the card? And there are 7 numbers on the card, but the card actually, the digits are actually ones. And so that confuses people. It's a conflict. It's can trip them up. So it's a moderately difficult task to do correctly. And what we did is on half of the trials, people just performed the task. And on the other half of the trials, they performed the task while we were giving them a similar pain stimulus to what they received initially. Okay, and then we measured their performance in terms of reaction time. And what we found was that the degree to which they attended to pain, the degree to which they had intrinsic attention to pain, predicted how much the task would interrupt, or the pain would interrupt their performance on the task. So individuals with high intrinsic attention to pain had poor performance on the task while pain was going on because the pain distracted their attention. They were unable to attend away from pain. And we found that individuals with high intrinsic attention to pain had lower functional and structural connectivity between the periaqueductal gray and the medial prefrontal cortex, which you'll remember as part of the default mode network. Perhaps this indicates a reduced ability to engage the descending modulation network on the basis of an individual's present cognitive state. That's something, we're still investigating and so on. Now, one question we're interested in as we figure out, okay, what is intrinsic attention to pain? What makes somebody intrinsically attend to pain? Question we're interested in is what accounts for that. Is it because people just simply feel incoming nociceptive signals more strongly, or because of some top-down attentional process that allows them to disengage? To examine this, this is very recent data from my lab at the University of Reading by my grad student, Greg Adams. We examined a couple of dynamic quantitative sensory measures, temporal summation and conditioned pain modulation. Now, temporal summation is a measure of wind-up. So you give people a nociceptive stimulus, a bunch of nociceptive stimuli in quick succession, and you see the degree to which they have summation or increased sensitivity due to that fast presentation. Conditioned pain modulation, or CPM, is a measure of how pain in one part of the body inhibits pain at another. And what we find is that individuals with high intrinsic attention to pain have more temporal summation and less inhibition of one pain stimulus by another, or less CPM. Now, David Yarnitsky has referred to this profile as a pro-nociceptive phenotype, suggesting that individuals with high attention to pain are highly sensitive to nociceptive input. So this might be a good marker of pain vulnerability. Another behavioral marker we've become interested in is trait mindfulness. As you probably know, mindfulness is a state of non-judgmental attentiveness to the present moment. Now, there's been a lot of literature in recent years documenting what happens when we train people in mindfulness, or study of people who have been meditators for decades and decades. But we can also examine it as a trait, regardless of people's previous experience. And this is really important if you want to use it as a marker for individual differences, because it needs to be applicable to everybody, not just a monk sitting up on a mountain in Nepal, or not just somebody who has been in mindfulness training for weeks or months. Okay, so we measure it as a trait regardless of people's previous experience. The work I'm going to show is from my lab at the University of Reading. Richard Harrison is the lead author, and this came out 2018 in the Journal of Pain. So, in fact, trait mindfulness does seem to be a good marker of pain responsivity, both sensory and emotional aspects of pain. We find that individuals high in trait mindfulness have higher pain thresholds and lower levels of pain catastrophizing. Now, earlier I mentioned that the default mode network has been implicated in chronic pain, as well as mindfulness, so that was a natural place for us to look when trying to link behavior with brain networks. So we used a seed in the precuneus because of its role in the default mode network. What we find is that trait mindfulness is associated with higher connectivity between precuneus, the seed you see in green on the bottom, and the primary somatosensory cortex. This pattern of connectivity was also correlated with pain threshold and pain catastrophizing. Okay, so this may serve as a good marker of resilience. What it seems to suggest is that individuals who are resilient to pain, as measured by high trait mindfulness, low catastrophizing, and high pain threshold, have strong connectivity between the default mode and somatosensory regions of the brain. And then finally, I'm going to show you a quite recent paper that came out in the journal Pain. The Vipka Gandhi, my postdoc at the University of Reading, is the lead author on this. It came out in just this year. Earlier in the talk, I talked about the negative cycle of stress and pain, how being in a state of distress or stress can facilitate pain, and how some individuals seem to get very caught up in that and get on this negative downward cycle. So what we were very interested in was who was most vulnerable to this, who's most likely to experience an increase in pain when experiencing negative emotions. And here's the design we used. At time 1, we had people do a resting state scan. And then at a second time point, we had them back in, and we showed them 2 types of slides. We showed them slides meant to evoke negative emotions, so, pictures of decaying corpses and dismembered hands and people pointing guns. Quite unpleasant, to be honest. And we showed that for 30 seconds, and in the last 12 seconds, we gave them a pain stimulus. And we compared their ratings on that pain stimulus to a neutral condition, where they saw neutral pictures of, spoons and cows and lamps and things that cause no emotional reaction. And so basically we just compare their ratings when in a negative emotional state to their ratings in a neutral state. And what we find is that individuals whose pain was increased greatly by that negative emotional state had high levels of connectivity between the amygdala and primary somatosensory cortex and a number of other regions. So just to summarize what I've been showing, in terms of pain vulnerability, we found that high levels of intrinsic attention to pain are associated with low connectivity between periaqueductal gray and the medial prefrontal cortex. And high intrinsic attention to pain is also associated with a pro-nociceptive phenotype, as characterized by high temporal summation and low inhibition of pain by other pain. We also found that individuals prone to high levels of emotional facilitation of pain had high connectivity between the amygdala and primary somatosensory cortex. And finally, we found that pain resilience, as operationalized by high levels of trait mindfulness, had high levels of connectivity between the default mode network and primary somatosensory cortex, low levels of pain catastrophizing, and high pain threshold. Hey, what's that noise? Better investigate. Huh. Hey, love, what you doing?
Learning violin.
Nice. Keep it up. Truth is, she's not very good yet, but it's really important that we do these kinds of projects. Oh, she's got a whole list going. Learn violin, build treehouse. Oh boy. Things are getting serious. Uh-oh. Hey, what are you doing, Millie?
Eating homemade French fries.
You made French fries? Nice. Truth is, this is a scary time in the world. There's so much going on and we're all stuck and isolated. So these kinds of projects, paint rocks, are really important. If we want to look out for our patients and for our loved ones, we have to do whatever we can to keep our mental health going. Make the dog pretty. Oh boy. Oh no, look what's happened to the poor doggy. Hey Juno, hi puppy, pretty puppy. The studies I just showed are promising in terms of understanding mechanism, but these kind of markers are only clinically useful if they help us steer treatment. A key detail in this sense is whether they help us predict either the development of pain or the response to a given treatment. The studies I showed are in healthy populations, and we don't really know whether a particular brain or behavioral measure is a predictor of pain responses or is a result of pain responses. For example, we don't know if trait mindfulness would help us predict whether someone was likely to catastrophize about a clinical pain they developed. So, an ideal solution is to use longitudinal designs that would allow us to see how these markers might predict someone's response to ongoing pain, or perhaps to a treatment aimed at reducing long-term pain. A second question is how they relate to each other. Are these potential biomarkers explaining the same small portion of variance, or might they complement each other? For example, if we know somebody's level of trait mindfulness, does it even help us to know their intrinsic attention to pain? Or are they basically separate measures of the same underlying thing? Another possibility is that they interact with each other. In other words, that their influence on pain response is non-additive, and that if we know both, we know more than if we knew each one separately. As an example, the precuneus, in the studies we just showed, the precuneus and the amygdala both interacted with somatosensory cortices, but one was a predictor of resilience and another a predictor of vulnerability. That raises the possibility that they have sort of a push-pull relationship in terms of sensory processing, and that when somebody is experiencing a nociceptive stimulus, we will know the most about how that is being processed in the brain if we know how both of these regions are interacting with the somatosensory cortices. So the last study I'm going to show is one I did a number of years ago, again in Karen Davis' lab. And the reason that I'm going to show this one is that I think the approach here is one that may help us answer those two questions. So central sensitization is a known contributor to some of the mysterious symptoms we observe, or sometimes when pain is out of proportion to the apparent level of injury, central sensitization is involved. And this has been shown to be involved in, disorders like fibromyalgia and osteoarthritis. And as a psychologist, I'm clearly very interested in whether it can be influenced by psychotherapeutic interventions. In order to study central sensitization, we looked at secondary hyperalgesia. Now, hyperalgesia is an enhanced pain response to a stimulus that would normally cause pain. Primary hyperalgesia is sensitivity at the wound site. So in the picture we've got here, I've got a little red square, and that is the area where we stimulate, where we provide a pain stimulus, thermal stimulus. Now, if after stimulating we sort of gave a mechanical stimulus, say we poked them with a pencil inside that red box, and they were extra sensitive, we would call that primary hyperalgesia, and that is known to be a function of the periphery. If, however, I took the same mechanical stimulus and I poked along several axes outside of the red square, and I noticed enhanced sensitivity, that would be secondary hyperalgesia. And secondary hyperalgesia is known to be a function of sensitization at the spinal cord and brainstem. So here's the longitudinal design that we use to study how central sensitization might change over repeated stimulus and in response to an intervention. So we gave people 10 one-hour-long sessions over a period of 2 or 3 weeks. At the first and last session, we just gave them, we measured their sensory thresholds and administered some questionnaires and so on. At the other 8 sessions, we gave them 45 thermal pain stimuli, 8 seconds long. And at the first and last session, the first and 8th session in pink, we also measured secondary hyperalgesia at the end of the session. Okay, so we got kind of a before and after measure of secondary hyperalgesia, just to see how central sensitization would change over 8 sessions. At all 8 sessions, individuals got a short 5-minute cognitive intervention. And which intervention they received depended which group they were randomized into. Individuals who were randomized into the regulate group were given a pain-focused CBT intervention. Okay, and so we talked a lot about their thoughts about the pain stimuli they were going to receive. Was there something that frightened them about it? Did they think it was going to be beneficial or harm them? What were some coping strategies they've used in the past, and could they use them now, and so on? We basically coached them in how to cope with pain. In the control group, we also gave them a 5-minute cognitive intervention, but it had nothing to do with the pain stimuli. It was an interpersonal intervention just to help them communicate with their friends and to negotiate in a stronger but kinder way. So that was a control for just receiving a cognitive intervention and receiving attention from the experimenters and so on. But it was not used to help them cope with pain at all. So at all sessions, we took measures of pain intensity and pain unpleasantness. And what we observed is that over the 8 sessions, we had a significant drop in pain intensity in both groups, an equal drop. Where it gets more, so basically they habituated over the 8 sessions. But where it gets interesting is the unpleasantness ratings. We noticed that the regulate group, the group that received pain-focused CBT, had significantly greater reduction in pain unpleasantness over the 8 sessions. Now this is cool, but it's kind of what we would expect from CBT, right? Because we are talking to them about the meaning of the pain and telling them it is not as frightening, in some way we're telling them it's not as frightening as they think it is. And so we would hope that that would reduce the unpleasantness of pain. So in some ways you could even call this a manipulation check. It's just to see, is our CBT intervention kind of doing what we would expect it to do? A more unexpected and to me exciting result was when we looked at secondary hyperalgesia. So here you see subtraction scores, and what we find is that the regulate group, the group who received the pain-focused CBT, had a significant reduction over the 8 sessions in secondary hyperalgesia, and there was no reduction in the control group. Okay, so this is quite exciting. This suggests that how we think about pain actually can actively influence the sensitivity of skin around a wound. This is, to me, is a very cool mind-body intervention, and one that I think can help us better understand how, this negative cycle of pain and stress. So in terms of understanding that negative cycle better, I think the key question here is whether we can identify individuals at high risk of entering this negative cycle before it starts, okay? Because often by the time we see patients who are well into this cycle, it's almost too late. We don't get that far with a lot of patients once, they're depressed, anxious, in chronic pain, etc. It's a treatment-resistant group, and we would ultimately like to intervene a lot sooner and better understand the negative cycle that leads to that state. And I'm going to show a figure from that paper to illustrate how, where we think these individual differences might be. So each of these lines represents one individual and how they changed in secondary hyperalgesia from session 1 to session 8. Now, in the regulate group in blue, you see that most of the individuals drop in secondary hyperalgesia over the sessions. We have a couple of notable exceptions, though, that actually rise in secondary hyperalgesia. You could potentially see those as treatment non-responders, people to whom CBT just didn't have any effect. On the other hand, in the control group, we see a lot more of a dog's breakfast. People are kind of all over the map. We have a lot of people whose secondary hyperalgesia is rising over the sessions. We have a few people who remain flat, and we have quite a few people whose secondary hyperalgesia drops without any cognitive behavioral intervention. Now, it's possible that this is just experimental noise, but I want to raise a potentially more interesting possibility that these might actually be characteristic responses that we actually see, we might predict how people would respond if, for example, they had a new injury or responded to a surgery. That, some people are likely to sensitize over time and some people are likely to desensitize over time. So that's what we're very much interested in, is whether these kind of experimental individual differences map onto clinical individual differences in pain and treatment response. And so this leads us to some future directions that we're interested in examining. So we've been developing something that we're calling the modulatory capacity assessment battery. And modulatory capacity is a term we're using for an individual's propensity for central modulation of pain. Okay, how likely they are to modulate incoming nociceptive signals centrally. And what we'd like to be able to do is use this to predict outcomes. And so what we're doing, I mentioned as one of the questions that we're very interested in how these different measures interact and what is the best combination of measures that best explains somebody's individual resilience or vulnerability. And so to do that, we're using many different types of measures. We're using quantitative sensory measures, like temporal summation and conditioned pain modulation. We're taking neural markers, both of people's response to pain and resting state functional connectivity. And we're using a variety of psychological questionnaires and measures, including some of the ones we've mentioned, trait mindfulness and intrinsic attention to pain. And we're hoping that together across these different modalities, we can find an optimal assessment that will be able to tell us how somebody is likely to sensitize to pain and perhaps even their characteristic response to a given treatment. So basically the way it would work is that we would give the assessment battery prior to something happening. So we would give the assessment battery, take an initial assessment, and then observe how things changed over time, and then take a final assessment. So at the University of Reading, I'm running a Medical Research Council grant run by my students Rich Harrison and Greg Adams. And we're basically doing the same study I just showed you, the cognitive behavioral intervention, in a much larger sample. And we're taking that modulatory capacity assessment battery beforehand. And what we're hoping is that we'll be able to predict both which individuals sensitize most over those sessions, but also which ones respond to the cognitive behavioral intervention, okay? Because we're interested in knowing both who is best suited to a cognitive behavioral intervention, because why waste somebody's time? If this intervention isn't going to work for them, we'd like to steer them to something else. And also we would like to know which individuals are at highest risk after a surgery or after an injury. Who is the most likely to sensitize, and would it help us to intervene early in those cases? So we're hoping that the assessment battery will help us in that way. And there are many other ways we could use this in more direct clinical populations. So example would be post-surgical pain. So if we knew somebody was scheduled for a particular surgery, we could give the assessment battery prior to that surgery and observe how things change over time, and hopefully predict which individuals are most likely to develop pain and which ones seem to be most resilient, and develop profiles for that. And possibly we could then give an intervention and see whether there is a particular profile associated with that intervention. So this is how we are hoping to use this initial biomarker work we've done to, again, clear up some of that variance, some of those individual differences in both vulnerability and resilience to pain. And with that, I want to thank some of my collaborators. I've been lucky enough to work, with great groups at the University of Reading, University of Iowa, University of Wisconsin-Madison, University of Toronto, and University College London. And, without those people, none of this work would be possible. So I'll also encourage you to look me up on Twitter, Head Like Egg, and maybe we can continue this conversation online. Thanks, everybody. Bye.
All right. That was great, Dr. Salomons. Thank you so much.
Oh, you're welcome. It was fun. Fun to put together.
I love the interjections where you included, was that your son who came in and asked if you were wearing pants?
Yeah. It's kind of typical of how things go these days, isn't it?
Yes, it is. So there is just a couple minute time lag. So people are probably hearing the end of your talk. However, somebody has submitted a question. So I'm going to go ahead and there's a letter. It only shows so much of the question. So I'll just say the full thing.
Okay.
So Robin asks, could you recommend specific studies or articles you would direct surgeons and other doctors to on the importance of validating their patient's pain, exercise in pain response, and education in pain perception? But I'll just show the first half because we know what that last word is, perception. Right?
Yeah. So the second one I probably won't do that well at. Being a psychologist, we don't exercise.
Of course not.
A paper I really like that I am happy to post and send around is by Tate and Chibnall and Kakani. And unfortunately, I can't remember the title, but what I really like about it is that it speaks of this issue of symptom uncertainty and what doctors tend to do when symptoms are uncertain. So when, I had that picture early on where the doctor was saying, oh, you shouldn't have pain. And what tends to happen in that instance is, as I said, they write the pain off like, somehow this must be some product of psychological problems or something like that. And rather than listening and saying, look, because the real answer should be, we just don't understand it yet. I mean, you're allowed to say that as a clinician and a scientist. You're allowed to say, we just don't understand that yet. I believe that you're having pain, but we don't understand it yet. But unfortunately, what tends to happen then is that a lot of clinicians use what this paper by Tate and Chibnall and so on says is that we tend to use heuristics, and many of those heuristics are not good heuristics. So one of the heuristics is if a patient is highly emotional about their pain, then they're probably, they're probably exaggerating. Well, that's not a good heuristic, because pain makes people, any of you who live with pain or any of you who know people who live with pain know what that does. And so people like that get undertreated. The study also says that women get undertreated and minorities get undertreated. People of color get undertreated because these heuristics sneak in, right? And so I think that's a really important paper to talk to people about. I would also recommend The Challenge of Pain by Melzack and Wall, because these are, our most respected pain scientists. Unfortunately, both passed now, but they really talk about pain being a subjective experience and the difficulties of objective measures. For some reason, people distrust subjectivity, and they think, if we don't have some objective measure, somehow that pain isn't valid. And pain does not have objective measures. I'll say that as boldly as I can. There aren't objective measures of pain. If someone tells you they're in pain, they're in pain. And Melzack and Wall do a very good job of making the case for that in a very erudite way that, any clinician who wants to ignore that or scientist who wants to ignore that does so at their own peril.
And so we have another question here from ID, and she asks, if you're giving a battery of examinations, you are assuming there won't be any changes in the brain between the examination and the after results. Do you take into consideration the brain flexibility? And so again, because of the character limit, the Y is cut off there, but.
Yeah, absolutely. Yeah. And, I will tell you the problem with this work, we're 2/3 of the way into the study I mentioned. And, from any of this work I've done, it's not just the brain measures, because let's be honest, all of these measures reflect what's going on in the brain. A big problem is reliability, right? That if you take something when I was talking about intrinsic attention to pain, I talked about test, retest reliability, because you want something, if I'm going to answer 7 different ways on 7 different days, that's not characteristic of me. And part of the reason that you put all of these measures together is that you hope that you're able to capture something more reliable. So that's in a way how we take into account the brain flexibility, as in, what mood is somebody in on day, like your measurements will be somewhat different on, if on a day where you're depressed than on a day when you're happy, or on a summer day as opposed to a winter day. There's going to be all sorts of natural variation. And so the part of the reason behind having a large assessment battery is to, one measure corroborates the other, and you get a stronger measure together that is less prone to that kind of variability.
Cool. So we'll just wait just a few more moments to see if any other questions come up, because again, there's a lag and
okay,
somebody might be typing, going into the Ethernet.
Yeah.
So I was curious, what made you choose this specific topic for your presentation for the summit?
We're spending a lot of time on individual differences these days, because to be honest, I feel like it might be the biggest sort of unanswered or poorly accounted for question, is that anyone who observes people, if you give a surgery, let's say 100 people have a knee replacement, 20 of them might develop chronic pain afterwards. And in most cases, that is not due to some failure of the surgery or anything. We don't know what it's due to. And, by the time we get way down the road, they've had chronic knee pain then for months and months and months after, and it's starting to bother them. It's starting to it's disrupting their lives. They're not able to work, et cetera, et cetera. It's often too late. And so I feel like understanding those individual differences is really it's a critical question we have to answer if we want to treat people better, because we tend to get, by the time we see a lot of these patients, we're finding it very difficult to make inroads. And I feel like we have to understand vulnerability better from that angle.
Yeah, that's true. So I haven't seen any more questions come in, and I think we'll just give maybe another moment or two just to see. And then
Okay.
I'll just remind the folks who have the Backstage Pass, you did receive the link to log into the Backstage meeting after this presentation. Again, because there's a lag, just give us a few minutes to join. And it looks like we had another question come in. So it's a good thing we're being patient. So let me just bring it into the room. And so Evie asks, does mindfulness training increase trait mindfulness?
That is a really great question. We're actually not certain, because you could kind of guess at it two ways. You could say that actually maybe the people who most benefit from mindfulness training are people who already have some trait mindfulness. Okay, so for example, I often think that the reason that academics are so into cognitive behavioral therapy is because it reflects how we think. We overthink everything. We spend our whole day in our own heads, and so we can really relate to cognitive behavioral therapy. I've had patients before where you say, okay, what thought were you having while that was happening? And they look at me like, no thought. I wasn't having a thought. I don't sit here. I don't do that. So, it is possible that the people who will do well with mindfulness are people who already have some proclivity for it, or, but it is also possible that, low mindfulness individuals will be the ones who will benefit most from training. So, to me, it's an empirical question that is very, very worth answering. Because really, towards the end, that's what I was more talking about, is like, how do we steer people towards a treatment that they're likely to benefit from, that they're going to believe in, that they're going to engage in. And, because one of the big predictors of outcomes in psychotherapy studies is the degree to which people buy into the treatment and the degree to which they feel a bond with their therapist. And those come from being prescribed to the right person and the right treatment. So I think that, those are really critical questions.
And we did have a couple more come in. Linda asks, can you address the role of memory in the development of secondary hyperalgesia?
Not specifically from data. I'm very, I think, our study is one of the first to, link cognition and so on to secondary hyperalgesia. But I will say, I'll definitely say I think if I was, to give you my strong hypothesis, it would be that memory is going to play a huge role, because how normally we develop central sensitization is through repeated experience. Okay, if we have repeated experiences of pain, we will quite often become sensitized to that pain. Well, if we have repeated unpleasant events occur to us, we're likely to remember that. So our memories are forming at the same time as our spinal cords is sensitizing, or so on. So it would be impossible for me to imagine that those two are not locked together in some important way. And that, part of this, when we try to help people overcome pain, we are trying to help them build new habits and, overwrite memories. And I can't help but think that if you overwrite memories related to pain, and, that also some of those physiological central nervous system processes will change accordingly. And I think that's what our study kind of hints at. So yes, I think it's an excellent question. And I would, if people know of research specifically in that area that I'm not citing, please do let me know, because it's, I think, super cool.
Cool. And we have another question, which I find is interesting. It's a good question from Matt. And he asked, you cited early work from IASP that you disagreed with. Now that you've done some work with IASP, to your knowledge, have they come back around and revised their stance or changed their verbiage?
I'm glad. So whoever asked that is right on the money here, because that actually was in the text of my, when you give these talks, you're trying not to read right off your text, but so you miss a couple of the details. But yes, absolutely. IASP has come around. I apologize, IASP. Don't send your people out to have me snuffed. IASP has revised their definition, and I will be sharing soon. I taped an interview with Jeff Mogul about the process they went through, which goes through some of this. But if you look at the new IASP definition, which was the paper was published this year in Pain, if you look at the new definition, the actual definition hasn't changed very much at all. So they fought for 2 years over, 3 or 4 words.
One word, I think.
Yeah. But what has changed substantially is the note, the accompanying note. And I think that the new notes are excellent. If I'm putting my cards on the table, I prefer the old definition to the new one, even though they're not that different. I just find the old one a little more usable. The new one's a little clunkier, but the new notes are vastly improved in my, if for nothing else than that, this is usually for psychological reasons, which to me, you lost me right there. So thank you for bringing that up and allowing me to correct myself, or to not have the IASP thugs come to my door.
So I see we should be looking at the notes behind the definition, as opposed to the fact that the definition hasn't changed in its wordage very much.
The notes are much, but first of all, they're much more succinct, but they've, some of the more difficult and challenging stuff has gone. And for those of you who are pain definition nerds, you know that a couple of years ago, we had several different proposed definitions, one of which was from Ken Craig and Amanda Williams, who fought to get social elements into the definition, and those are in the notes now. So they have acknowledged, the important role that social and cognitive factors play. So I think the new notes are very strong.
Cool. And we have time. We have one more question. There may be time for one more if somebody can get it in while he's answering this one. This is from Jim Stark. Are there any clear tools to develop trait mindfulness?
No, I mean, I'm going to qualify that answer because as I said, we don't know yet whether you can change trait mindfulness. Particularly, I mean, the most interesting immediate possibility is that you could change it with a mindfulness intervention. But, the reason we're interested in it to some extent is that it exists prior to any training. So, like you can characterize people by trait mindfulness, regardless of what they've learned or what they know. But in some sense, what this is asking is, how stable is that trait? And that's always an issue with, supposed trait characteristics, right? That, well, not all of our traits remain stable. So we talk about trait anxiety. That's very much your level of trait anxiety is going to change if you get a divorce and lose your house. It's not going to remain the same. It's going to be influenced by your state. So I would imagine that you can influence trait mindfulness, but unfortunately, I don't know how yet. So.
All right. Well, this pretty much is the end of the live Q&A. I want to thank everybody who's watching again for attending and coming into the virtual space and giving it your patience to figure things out. I think everyone's figured everything out okay. So those of you with a backstage pass, we will move into the Zoom discussion. And for everybody else, you'll get a break until the next event, which is the meet and greet activity. So I hope you guys will show up. It's free for all attendees, and I have a really fun activity for everyone to do. But you have to show up, find out what